Welcome, everyone. I'm Alan Strozier, a member of the marketing team here at Precision Analytical, creators of the Dutch test. Thank you all for joining us today for our September webinar featuring Dr. Kelly Ruef, one of our Dutch clinical educators. Today, Dr. Ruef will explain the connections between adrenal hormones and PCOS. In this presentation, she'll investigate the etiology of adrenal PCOS and teach you how to spot high adrenal androgens. Dr. Ruef will also guide you through the 4 phenotypes of PCOS and highlight potential adrenal involvement that might be otherwise overlooked. Before we begin, I want to let you know that we have just launched the newest season of the Dutch podcast, where you can find even more hormone education. Season 3 is now available on your favorite streaming app, and each week we'll bring you insights from some of the brightest minds in functional medicine. With our host, Dr. Jacqueline Smeaton, we'll explore new perspectives on integrative healthcare and challenge common misconceptions about hormone testing, hormone replacement therapy, and much more. Find the Dutch podcast wherever you get your podcasts and catch up on this week's episode with Dr. Deb Matthew, where she and Dr. Smeaton discuss stress, cortisol, and the circadian rhythm. Please also rate, review, and subscribe to get access to all the new episodes as they post each week. And as always, we would like to extend an invitation to everyone joining us for the first time to become a registered Dutch provider. Dutch providers have access to exclusive educational resources like the Mastering Functional Hormone Testing course and the Dutch Interpretive Guide, plus one-on-one consultations with Dutch clinical educators and opportunities to learn alongside other new Dutch providers in group mentorship sessions. To become a provider today, click the link that we posted in the chat. Once you've completed the provider application form, a member of our onboarding team will walk you through the steps to set up an account and gain access to all the education and resources Dutch has to offer. Now, let me introduce today's speaker. Dr. Kelly Ruef is a licensed naturopathic doctor who completed her medical education at the National University of Natural Medicine in Portland, Oregon. She completed a private residency at Pearl Natural Health in downtown Portland, where she specialized in inflammatory bowel diseases and women's health. As a clinical educator here at Dutch, she is dedicated to educating providers on how urine testing can improve the field of women's health. With her background in biochemistry and cell biology, Dr. Ruef loves learning about the hormones and biochemical pathways in the human body, and she makes a point to share what she has learned through videos, blogs, social media posts, and podcasts, with the hope that her education will help all of us find happiness and health. So thanks for being with us today, Dr. Ruef. We're ready when you are.
Thanks, Alan. I'm really happy to be here, and thank you to you all for taking some time out of your day to learn a little bit more about adrenal PCOS with me. So let's just dive right in. Okay, so my name is Dr. Kelly Ruef, like Alan said. I'm a naturopathic doctor, but I'm also a clinical educator here at Precision Analytical. And if you want to find me on Instagram, my handle is Dr. Kelly Ruef. Ruef is R-U-E-F, and I'm mostly posting about menopausal hormone therapy these days. And remember, the information in this presentation, it's for informational and educational purposes only. I'm not giving treatment advice. I'm not giving medical advice. And any supplements that I talk about have not been evaluated by the FDA in the USA. Okay, so the objectives today, we're going to review PCOS. We're going to learn a little bit more about androgens, talk about adrenal involvement in PCOS. And then we have about 4 Dutch test examples to go over. And of course, at the very end, we're going to dive into those treatment considerations. So number 1, what is PCOS? It stands for polycystic ovary syndrome. A lot of you know that already. It's one of the most common endocrine disorders in women of reproductive age. And women with PCOS, they experience all sorts of signs and symptoms, irregular cycles, absent cycles, hair where we don't want it, on our face, on our body, hair loss where we don't want it, scalp hair loss, acne, mood issues, but it can also affect our fertility, our ability to lose weight, for example. And I think it's important to assess for and treat PCOS or diagnose PCOS because it really does increase risk for a lot of diseases and conditions that we need to be aware of. So it can increase risk for infertility. If women do get pregnant, they can have pregnancy complications, obesity and insulin resistance, diabetes, dyslipidemia, non-alcoholic fatty liver disease, metabolic syndrome, and even like issues with our cardiovascular system, sleep apnea, psychological diseases, endometrial hyperplasia and cancer, and more. So there's a long list here that we need to be aware of, monitoring our patients with PCOS. So a lot of us are familiar with the Rotterdam criteria of 2003. And according to this criteria, you need 2 out of the 3 to diagnose PCOS. Number 1, oligo and or anovulation. So that's usually irregular cycles or no cycles. Clinical and or biochemical signs of hyperandrogenism. So that's when their testosterone comes back on high on testing, or their DHEA-S comes back high on testing, or they have acne or hair loss, or these symptoms of high androgens. And then of course, polycystic ovaries. And there's 4 phenotypes. There's phenotype 1, 2, 3, and 4, and they're listed in order of decreasing clinical severity. So if you have phenotype 1, you're going to have more severe signs and symptoms than compared to phenotype 4. And phenotype 1 is the classic PCOS. You have all 3 of those criteria. You have the polycystic ovaries, you've got the high androgens or the high androgen symptoms, and you've got the irregular cycles or absent cycles. Phenotype 2 is a little different. You've got the high androgens and the irregular cycles, but maybe not the polycystic ovaries. Phenotype 3 is interesting. It's also called a ovulatory PCOS. And only about 10% of the cases are this phenotype 3, but these women still have regular cycles, but they have the polycystic ovaries and the high androgens. So it's a good thing to remember that women with PCOS can still have regular cycles. So if they have regular cycles, it doesn't automatically mean that there's no way they could have PCOS. They could. And phenotype 4, this is non-hyperandrogenic PCOS. So they have polycystic ovaries, they got the irregular cycles or absent cycles, but no high androgens, no high testosterone, no acne, no symptoms of androgen excess. So it's possible too, it depends on what criteria you're looking at, but it's possible too to have PCOS and not have high androgens. So there's different types of PCOS. 2 that I have listed here are functional ovarian hyperandrogenism, so high androgen production from the ovaries, and then functional adrenal hyperandrogenism, and that's mostly high androgen production from the adrenals. And the ovarian one is the most common, of course. 87% of cases have that ovarian involvement. Usually it's due to some sort of, it's due to a couple of different things, but one cause of this functional ovarian hyperandrogenism is intrinsic enzyme dysregulation. So the 1720 lyase and the 17 hydroxylase, they're dysregulated. They're not working like they should. So the ovaries overproduce androgens. And of course, we know insulin resistance and increased luteinizing hormone can worsen the ovarian output of androgens. And remember, in PCOS, a lot of times we see LH being relatively higher than FSH. The functional adrenal hyperandrogenism, it's not as common as the ovarian one. And isolated FAH, so these women who don't have any ovary involvement, it's pretty rare. It's 5% of cases, but it does happen. I really got to put this in here. Part of the Rotterdam criteria also says PCOS is a diagnosis of exclusion. So we have to rule out other common diseases that can present with similar symptoms as PCOS. So I have them listed here. We always want to make sure we rule these out. And it's interesting, but sometimes people have high prolactin because they have hypothyroidism. So make sure to do this workup. Here I've circled all the ones that could potentially result in increased adrenal androgen production. One thing about hyperprolactinemia, if someone has like a prolactinoma or their prolactin gets really high, then you tend to see sex hormone suppression, not high androgens. But if it's just a little high, maybe they're stressed out, maybe they're over-exercising, maybe they're taking certain medications like a proton pump inhibitor, those can increase prolactin. Hypothyroidism, again, can increase prolactin. And if the prolactin is slightly high, it actually sensitizes the adrenals to the ACTH signal. So if a woman has prolactin that's a little high, it could cause her adrenals to overproduce androgens. So let's talk about androgens. And from the Oxford languages, an androgen is a male sex hormone, such as testosterone. But we have a lot of androgens in our body. It's not just testosterone. We're going to go into a few other ones. And mostly, we think about testosterone and androgen in relation to muscle mass and strength and stamina and, hand wrestling, arm wrestling and erections, but it's not all about that. They also support our bones, our skin, our hair, our mood, our memory, our fertility, our sexual function, our libido, our estrogen levels as women, and even cardiovascular health and immune health. So it's not just about muscles, not just about strength, it's not just about erections in men. It does a lot more than that. And if androgens get too high, we start to have problems, right? So we tend to see a lot of these signs and symptoms in our women with PCOS. They might have acne, they might have that hair loss, or they might have, facial hair, the hirsutism, or body hair growth, more around their belly buttons, their nipples. They can have more mood issues, fertility issues, irregular cycles, and of course, weight gain. But I know this presentation, we're not really, going to address low androgens, but I do want to say our androgens, we want them to be in that sweet spot. We don't want them too high, and we also don't want them too low. Because if they're too low, we might not be able to exercise or build our muscle mass. We're going to have poor recovery. We might have more injuries, more issues with our bones, our ligaments, our joints, our tendons. We might gain weight more easily. It can set us up for risk for osteopenia, osteoporosis, memory issues, brain fog, mood issues. Sometimes you'll see depression with it, fatigue, low libido, infertility, and of course, cardiovascular and immune dysfunction. So androgens are really important. And for women, we do want androgens. We just don't want a ton of them. Okay, so let's talk about androgens specifically on the Dutch test. Remember the Dutch Complete, this is our signature product. It's 4 urine collections over the course of 12 to 16 hours. So we've got these 4 urine strips here, and people pee on the strips, or they pee in a cup and they dip it. But they're usually taking a dinner time sample around 5 p.m., a bedtime sample when they go to bed, and then a waking sample right when they wake up, and then a sample 2 hours after they wake up. It's really easy to collect from home. There's no needles involved, which is my favorite part. And it's very comprehensive. We're measuring androgens, which we're going to talk more about, estrogens, progesterone metabolites, cortisol, and organic acids. So these are the androgens that we measure on the Dutch test. These are the important ones. And you'll notice on the left here, we have testosterone metabolites. So we have, of course, testosterone, and then some downstream testosterone metabolites like 5-alpha DHT and 5-alpha and 5-beta androstenediol. And then we have 3 DHEA metabolites. I think of these as the adrenal metabolites. So DHEAS, etiolanolone, and androsterone. But just remember, and I'm going to say this again later in the presentation, DHEA can convert over to testosterone and influence these testosterone metabolites. And to some degree, testosterone can convert over and influence etiolanolone and androsterone levels. So it's not like all the DHEA metabolites are coming from the adrenals and all the testosterone metabolites are coming from the ovaries. I wish it was that cut and dry, but it's not. But in general, those DHEA metabolites, a lot of them come from the adrenals, and the testosterone metabolites, a lot of them come from the ovaries. Here we've got this steroid pathways chart. You probably can't see it, It's probably very small. But if you download the Dutch Interpretive Guide on the provider portal, it's on page 38. It's very clear. You can see how all of the hormones are interconnected. And you'll notice all the solid colored boxes are metabolites that the Dutch test measures. All of the kind of hollow ones are ones that we don't measure. But a lot of these are solid. Like, this test is pretty comprehensive. We're looking at a lot of sex hormone metabolites and cortisol metabolites. Okay, so this talk, we got to talk about alpha versus beta when it comes to the androgens, because alpha metabolites are very potent metabolites. Alpha metabolites are more androgenic, they're potent, they're the ones acting on the androgen receptor at the target tissues. Whereas beta metabolites, they're really weak. They don't really act on the androgen receptors at the target tissue. So the alpha metabolites that we measure are 5-alpha DHT and 5-alpha androstenediol and androsterone. The beta metabolites we measure are 5-beta androstenediol and etiology. I kind of try to make this visual representation so you can really soak it in and remember, but the way I remember alpha is more potent is I think of a gorilla and I think of the alpha male, because they do tend to have more testosterone. The alpha male, sometimes, they might get aggressive if they've got a lot of testosterone. But basically, testosterone gets metabolized into 5-alpha DHT, and it gets metabolized by 5-alpha reductase enzyme. And vice versa, it gets turned into 5-beta androstenediol by 5-beta reductase. And then 5-alpha DHT gets converted all the way down to 5-alpha androstenediol. So the ones in red, the alpha metabolites, ones in blue, beta metabolites. Same with DHEA. DHEA can be sulfated to DHEAS, or it can convert down to androstenedione and then down to androsterone and etiolanolone. And in this case, androsterone is the alpha. And A, androsterone starts with A. Maybe that's how you can remember it. It's alpha. Etiolanolone, beta. So since testosterone and the alpha metabolites are the ones acting on the androgen receptors at the target tissue, when I want to get an idea of the androgen activity in someone's body, I'm focusing on these metabolites. These four right here, testosterone and then the alpha metabolites. And it's important to know that the amount of local 5-alpha reductase activity and the concentration of androgen receptors modulate the extent of androgenic effects of testosterone in target tissue. So if you're in the target tissue, let's just say you're in like chin area. If you've got a lot of 5-alpha reductase enzymatic activity, you're going to convert more testosterone into these potent active alpha forms, right? You're going to have more 5-alpha DHT hanging out here. And of course, if you have more androgen receptors, the 5-alpha DHT is going to have more of an effect in those tissues. So here's a few more important notes about the androgens. Number one, DHEAS is the sulfated bound up form of DHEA. And some people, they don't sulfate well. So it's possible that someone's DHEAS could be normal low. Let's say we measure in the blood, their DHEAS comes back normal. It could come back normal even if their adrenals are overproducing DHEA. Because if they're not sulfating well, you're not going to find a lot of it in the sulfated form. DHEA and androstenedione, they're considered prohormones. So they don't act on the androgen receptors. They don't have that effect. They have to first convert downstream, whether that's testosterone, 5-alpha DHT, or estrogen, to actually have an effect in the body. And I already said this here, to evaluate androgen activity in the tissues, pay special attention to that testosterone and those 3 alpha metabolites that we're measuring. And of course, testosterone can act on androgen receptors. Testosterone is not a prohormone. It's an active hormone. It'll act on those receptors. 5-alpha DHT is 4 times more potent than testosterone. 5-alpha DHT is our most potent androgen. But it turns out that 5-alpha androstenediol might better represent 5-alpha DHT levels in the tissues than actual 5-alpha DHT in the urine or the serum. And why is that? You're like, why is that? That doesn't make any sense to me. Okay, so think of it this way. 5-alpha DHT, most of it is made and metabolized right there in the tissues. Most of it is just hanging out in the tissues. It's not circulating in the blood. So if you measure 5-alpha DHT in the blood or even in the urine, it could come back normal, even if 5-alpha DHT in the tissues is elevated. If we really want to know, we could do a tissue biopsy, but I personally don't want to do that. So the research is saying, look at 5-alpha androstenediol, which is the downstream metabolite of 5-alpha DHT. And you'll see this, I see this on Dutch tests all the time. 5-alpha DHT comes back normal, but 5-alpha androstenediol comes back high. And then I start to think, oh, their DHT levels in their tissue might actually be on the high side, maybe not normal. And lastly, androsterone, remember it's the alpha DHEA metabolite, is weaker than testosterone. But it still has an effect on those tissues, remember? Okay, so let's jump into adrenal involvement in PCOS. That's why we're all here, right? So between 20 and 30% of women diagnosed with PCOS also have excess DHEAS. And remember, most DHEA comes from the adrenal, so this indicates hyperfunction of the adrenal cortex. And this is one of my favorite points to talk about. If you ever do consults with me, I talk about this a lot. The adrenals make androgens too. And in women, no matter what age they are, their adrenals are contributing a substantial amount to their androgens. It's not just the ovaries. And you can see it here. So ovaries are on the left, adrenals are on the right. This just tells you percentage-wise how much they're contributing to each of these androgens. And look at that. The adrenals are contributing most of the DHEA and about the same as the ovaries for androstenedione and testosterone. So the adrenals are playing a huge role in our androgen production. That's why we have to take care of them, especially as we get older. You know, our androgens decline as we get older. And if we're stressed out, if we're in chronic pain, if we're over-exercising or under-exercising, you know, that really does affect our adrenal health, and our androgens are going to drop off way faster. So what causes adrenal PCOS? It's unclear. Surprise. Yeah, it's unclear. Of course it's unclear. But we know a little bit of information that might help a functional medicine approach to care. So it's probably a combination of factors. Number one, hyper-responsive adrenals, and they're overproducing androgens. Genetic factors. It's associated with premature adrenarche. And then, of course, stress and higher cortisol is just going to make it worse. What signals the adrenals to make androgens? So remember, the adrenocorticotropic hormone, or ACTH, is what promotes the release of cortisol and androgens from the adrenal cortex. And here, there's a visual diagram. I really like this because it shows that, so we have 2 adrenal glands and they sit on top of the kidneys. So we have 2 kidneys, 2 adrenal glands on top of those kidneys. And on the outer portion, it's kind of beige in this picture, that's the cortex. And the cortex makes our androgens like testosterone and DHEA, makes our mineralocorticoids and our glucocorticoids. And an example of a glucocorticoid is cortisol. So we step back a little bit, we can see the signaling pattern here. So see the hypothalamus in the brain. It's releasing corticotropin releasing hormone, or CRH. CRH goes directly to the pituitary. The pituitary responds by releasing ACTH. ACTH makes its way through the body, goes to the adrenals, and causes the adrenals to release cortisol and androgens. And within the cortex, within that beige part, outer part of the adrenals, we have different zones. There's 3 different zones. And it might be interesting to know that the androgens come from the zona reticularis. You'll hear me say this again. And cortisol from the zona fasciculata. So they're coming from different zones. There's usually a negative feedback. So if the brain should be able to sense that there's high cortisol. And if the brain senses, oh, there's high cortisol, the brain should kind of shut down or lower its signaling so that cortisol doesn't get out of hand. But sometimes if we have high adrenaline, it can interfere with this process. All right, so one cause of adrenal PCOS is hyperresponsive adrenals. And I wanted to show this because it's kind of like a steroid pathways, kind of like it tells us how produced within the zona reticularis, you know, the zone that makes the DHEA, the testosterone. So ACTH, remember, promotes the release of adrenal androgens from the zona reticularis. And in the zona reticularis, there's low expression of this 3-beta HSD2 enzyme, these 3 here right in a row. But there's enhancement of 1720 lyase and SOLT2A1. So if you're pushing this pathway, and you're inhibiting these pathways, hopefully you can see my cursor. I mean, you can see here, you're gonna produce a lot of DHEA, a lot of DHEAS, a lot of androstenedione. And with women with the adrenal component to their PCOS, their zona reticularis is hyper-responsive to the ACTH signal from the pituitary. And sometimes that zona reticularis is hypertrophied, it's bigger. It's got a bigger response to ACTH. This is significant because even if they don't have any HPA axis dysfunction, if they don't have high cortisol, they can still over-respond and overproduce adrenal androgens. And in functional adrenal hyperandrogenism, adrenal androgens are formed in the zona reticularis disproportionately to cortisol formation in the zona fasciculata. After age 30, though, our DHEA starts to decline, but it's not due to lower ACTH signaling. It's actually due to lower enzymatic activity, especially that 1720 lyase. So as we get older, you know, it's not like our cortisol is declining unless we're really stressed out. It's more so the enzymatic activity in our zona reticularis is kind of going downhill. So we're not making as many androgens. And for women with PCOS, sometimes this can be a good thing. You know, sometimes, most of the time, androgens will decline as we age. But this tells us that the enzyme function, the enzyme activity in the adrenals is just as important on androgen adrenal production as the ACTH signal. So there are genetic factors relating to adrenal PCOS. We have the PAP synthase 2 deficiency. This results in lower DHEAS. And that's because the PAP synthase 2, it's what provides the universal sulfate donor, PAPs, to all sulfotransferases in the human body, including SOLT2A1. And remember, SOLT2A1 sulfates DHEA to DHEAS. So basically, with a PAP synthase 2 deficiency, don't have enough sulfur donors or sulfate donors. And so DHEA just doesn't really get converted to DHEAS. Instead, it's probably getting moved downstream towards testosterone, towards 5-alpha DHT, which are active in the tissues, right? Which can cause acne if they get too high. And of course, there's also documented genetic variants in the SOLT2A1 itself, which basically slows it down so it doesn't sulfate DHEA as much. So if we're not sulfating DHEA, it might be going down, more down into active testosterone, active 5-alpha DHT. And there's likely an interaction of genetic and environmental factors, both contributing to the etiology and the signs and symptoms of PCOS, because there is a high heredity of elevated androgens. A lot of times, if mom has high androgens, if mom has high testosterone, high DHEA, daughter will have high testosterone, high DHEA. But on that note, inherited enzyme defects, they only account for a very small fraction of women suffering from these high adrenal androgens. So rather, they're saying it's probably more so due to this hyper-responsive adrenal zona reticularis. Premature adrenarche. So remember I said that premature adrenarche is associated with PCOS. But what is adrenarche? I feel like I never learned this in school. But adrenarche is when the adrenals go through puberty. And it usually happens around like 9 or 10, but it's considered premature if it occurs younger than 8 years old in girls or younger than 9 years old in boys. And this is when the zona reticularis develops. Makes sense, right? So the adrenals are going through puberty and their zona reticularis, which is responsible for making those adrenal androgens, starts to develop, starts to get bigger. And in effect, DHEA and DHEA levels start to rise. But during adrenarche, it's not like cortisol and ACTH starts to rise. No, cortisol and ACTH are, from my understanding, pretty consistent throughout our lives, unless we have HPA axis dysfunction. It's more so in adrenarche, the zona reticularis gets bigger, hypertrophies, and that ACTH signal has a bigger effect on the zona reticularis. They start making more DHEA, more testosterone. And premature adrenarche has a 15 to 20% increased prevalence in PCOS. So if you've got a young one who's going through adrenarche early, might, it's associated with PCOS. I'd be on the lookout for that. I just keep it in the back of my mind. Some people say that functional adrenal hyperandrogenism is like an exaggeration of adrenarche. Maybe it's hypertrophying or getting bigger, a little too much. All right, stress. Let's talk about stress. So I showed you this slide already. What happens in stress? So first of all, your brain looks like this, which is not good. Trust me, my brain has looked like this before. It's not good. You can feel it, right? The hypothalamus is just sending a lot of signaling to the pituitary, and the pituitary sends a lot of ACTH signaling to the adrenals. And the adrenals say, oh my gosh, we really got to up our cortisol. And so cortisol is usually above range or on the high side. And a lot of times DHEA and adrenal androgens will increase too. So, gosh, an example of the opposite, if you take prednisone suppresses adrenal output of cortisol. So you see this on Dutch testing. Someone takes prednisone and then they accidentally test a week later and their cortisol is super low. It can affect their adrenal androgens too. Their adrenal androgens can be really low too. It just suppresses the whole thing. But we want our brain to look like this. Sometimes we want our brain to be in stress mode. It's important when we're running away from a bear. But for the most part, we want our brain to be happy. And we want normal ACTH signaling, normal cortisol, normal androgens. And it's just yet another reason to give your brain some love. Take some downtime, read, meditate, work out, but don't over-exercise. So let's talk about evaluating androgens in suspected adrenal PCOS patients. So remember, DHEA can be sulfated to DHEA-S, or it can convert over to androstenedione and down to testosterone and 5-alpha DHT. And the hormones, the 3 hormones here that are in that kind of beige yellow color, those are not active. They're not acting on androgen receptors. The ones in blue are active. They are acting on androgen receptors. And DHEAS, it's not always elevated in adrenal PCOS. And this could be because DHEA and DHEAS don't freely interconvert. And of course, DHEA can directly convert over to androstenedione and testosterone and 5-alpha DHT instead of DHEAS. And like I said before, some people have impaired sulfation. Maybe they have the SULT2A1 genetic variant or the PAP synthase 2 deficiency. They don't sulfate well. So their DHEAS, like if you do a DHEAS measurement in the serum, it comes back normal or low. If they're not sulfating well, it might not represent their DHEA levels well. So people say, well, let's just measure DHEA in the blood. But, you know, that comes with its hiccups too, because DHEA has a short half-life, like minutes. Half-life is minutes, and it has a diurnal pattern. So its levels are variable throughout the day. Therefore, measuring the downstream metabolites of DHEA in the urine, like etiocalanolone and androsterone, might provide more insight into the adrenal overproduction of androgens. Remember we saw this. So DHEA can go into androsterone and etiocalanolone. So when I'm trying to get an idea of where androgens are coming from, when I'm looking at a Dutch test, if these 4 metabolites on the left are really elevated, I start to think, okay, probably coming from the ovaries. But if a lot of the metabolites on the right here, you know, the DHEAS, the etiocalanolone, the androsterone, if those are elevated, I start to think, well, maybe more are coming from the adrenals. It's not cut and dry, remember, but can kind of give us some clues. So let's go through 4 test examples. We got example number 1, 34-year-old female. She was diagnosed with PCOS, struggling with hair loss, hair thinning, acne, anxiety, normal BMI, and irregular cycles. And if we go to page 3 of a female report, it's a nice visual layout of the sex hormones. We'll notice that, do you see this? All 3 of her DHEA markers are elevated. They're all elevated. So I start to think, okay, there's probably some adrenal involvement, right? Go back to page 2 on a female report. You'll get more information about the downstream testosterone metabolites. Like remember the ones I'm most interested in are the alpha metabolites. So 5-alpha DHT, 5-alpha androstenediol. And hers are, you know, pretty normal, maybe a little bit high. A little bit high. So I think, okay, maybe ovarian involvement, but I'm betting on adrenal involvement. We look over at her cortisol on page 5. Look at this, cortisol, it's actually normal low. But of course, she could still have that hyper responsive zona reticularis to her ACTH signal. So even in this case, I'm still going to be supporting the HPA axis, supporting the circadian rhythm, working on stress reduction. Okay, example number 2, 32-year-old female, so similar age, with suspected PCOS, struggling with hair loss, increased body facial hair, and moderate anxiety. Her BMI is considered obese. She's got known dysglycemia and insulin resistance and irregular cycles. And look here, all 3 of her DHEA metabolites are elevated. So I'm thinking, okay, probably adrenal involvement. Her testosterone, it's within range, but honestly, that's getting towards the higher side from what I typically see. And her downstream testosterone metabolites, 5-alpha DHT, 5-alpha androstenediol, definitely above range. So definitely thinking, okay, ovarian involvement here too. Adrenal and ovarian involvement probably. And her cortisol, what does her cortisol look like? Yeah, it's pretty normal. Maybe some points are a little low. So maybe some hyper-responsive adrenals. Okay, example number 3. This is a younger woman, 20-year-old female. She's diagnosed with PCOS. She's got moderate androgen excess and anxiety. Her BMI is normal and regular cycles. And this is very different picture. Okay. So first of all, not all 3 of her adrenal androgens are elevated. DHEAS is actually low, on the lower side. But etiolcanolone and androsterone are way above range. So remember, some people don't sulfate well. So their DHEAS might come back normal or low. But because the etiolcanolone and the androsterone are so high, I'm still suspecting that there could be some adrenal involvement. And if I go back to page 2 of the female report, her testosterone's getting a little on the high side. 5-alpha DHT, normal. 5-alpha androstenediol, a little bit high. So like maybe ovarian involvement too. Yeah, I'm of course in all these people, I'm still going to look into insulin resistance, dysglycemia. I'm not going to like avoid the ovary involvement portion if I don't see high testosterone or testosterone metabolites. But look here, her cortisol actually high. If you look at her 2 graphs, so I look at the 2 graphs to get an idea of free cortisol in circulation. It's high. Her result here is the red line. If you look below the graphs, we add up the 4 cortisol points throughout the day to get the total, and they're both above range. And her metabolized cortisol. So when the body's done using cortisol and cortisone, it metabolizes it to THF and THE. And THF, THE, their cortisol metabolites, they're no longer active, they cannot be reactivated, but the cool thing is we can measure them in the urine. And usually if we find a lot of them, it tends to mean that they made a lot of cortisol that day. So in this case, definitely going to work on the HPA axis, stress reduction. I'm going to try to figure out what's increasing her cortisol. Because with these types of patients, if you can really calm down those adrenals, you can see a real effect, a real decline in their total DHEA. All right, and example number 4, how to show one of these examples. We actually see this, I'd say I see this quite often. Young woman with suspected PCOS, she's got some of these symptoms of high androgens, obese BMI, irregular cycles. But look at her testosterone, 35. And look at her downstream testosterone metabolites. Her 5-alpha DHT is very high. Her 5-alpha androstenediol is very high. So I'm definitely thinking there's ovarian involvement here. I'm going to test her blood sugars for sure. We're going to, weight loss is probably going to be an important component to her treatment plan. And her, 2 of her 3 DHEA metabolites are elevated, but remember, this could still mean she's got adrenal involvement. And actually, if we look at her cortisol again, look how high that is. So from this Dutch test, I got a lot of information. And for her, the good news is there's a lot we can work on, right? We have identified that there's likely ovarian involvement, likely adrenal involvement, definitely HPA axis dysfunction. So at the next follow-up session, you're going to have a lot of questions, a lot of follow-up questions to ask. Okay, let's dive into potential treatment considerations. And I just want to back up and say, we don't really know how to fix the genetic components. It's hard to know, like if someone has hyper-responsive adrenals, there's limited things we know how to do, what to do. We know that high prolactin can make the adrenals even more hyper-responsive. We know hypothyroidism can elevate prolactin. We know stress can elevate prolactin. Overexercise can elevate prolactin. Certain medications like proton pump inhibitors, dopamine antagonists, these can elevate prolactin. So there's like some things we can do, but a lot of what we're going to be doing with these PCOS patients are, we're going to lower their cortisol if elevated, reduce stress and anxiety, avoid intense exercise, avoid a sedentary lifestyle, regulate the blood sugars. We can use some herbal anti-androgens and natural 5-alpha blockers, support the circadian rhythm, and support sleep. So let's go back to this cortisol page. If there's high cortisol, got to figure out what's causing it and try to work on that. And it's not just stress and anxiety that elevates cortisol. There's a lot of things that can elevate cortisol. Intense exercise can elevate cortisol. So we don't want our PCOS patients working out intensely every day. It's not good for their adrenals, not good for their androgens. Pain. If you have a PCOS woman who gets migraines often, you see this on Dutch testing all the time. They report a migraine on the day they tested and their cortisol is off the charts. Like, it's amazing how pain or even illness can affect your cortisol. So if you've got a woman with PCOS, she's got high androgens and she's getting migraines all the time, if you can help reduce the pain from the migraines or the severity, how often it occurs, that's probably going to help her PCOS also. What else elevates cortisol? Inflammation, infection, blood sugar dips. Remember, when blood sugar dips, cortisol rises to bring more glucose into the blood. Caffeine, licorice, stimulants. Hyperthyroidism or too much thyroid medication. So it's really important to monitor that thyroid, make sure you're not overdosing. Obesity and Cushing's syndrome. So some things you can do. These are just some options, more tools for your toolbox. Of course, deep breathing. I really like the 4-7-8 breathing. So you breathe in for 4, hold for 7, breathe out for 8. But a good rule of thumb is if you want to relax, make sure your breath out is longer than your breath in. So if you breathe in for 4, you breathe out for 8, that's going to induce relaxation. That's going to induce the parasympathetic system. If you do the opposite, you breathe in for 8 and you breathe out for 4, that's actually going to promote sympathetic tone and increase heart rate, kind of wake you up. There's some great great apps out there for meditation. Insight Timer, I love Insight Timer, but here's a few to choose from. The Healthy Minds app is donation-based, so you don't have to pay for that one. And affirmations, the way we think about ourselves and our environment, can really help with situational stress and body image and overall cortisol levels. And of course, grounding exercises, journaling, yoga, prayer. Here's a bunch more things we can consider. Exercise. EMDR, the eye movement, desensitization and reprocessing, can be helpful for some people. There's actually an app that I like called Anxiety Release App. It's based off of EMDR. And that can really help with anxiety in the moment. I've actually had a practitioner tell me that all the nurses in her facility started using it for sleep, and it really helped them fall asleep. We've got emotional freedom technique, EFT tapping. I feel like that works really well. And actually, if you get the Insight Timer, they have a lot of courses that use EFT. I actually did a 15-minute course before this presentation. I went into Insight Timer, I typed in presentation, and I found an EFT tapping exercise to reduce anxiety before presenting. And I think it really worked. Heart math, this is like exercise for your nervous system. It helps balance sympathetic and parasympathetic tone, which is going to improve cortisol. Reducing caffeine, improving sleep, healing the gut, of course, really important. Social connection. We saw during COVID, what happened to people's mood. People probably had a lot of increases in cortisol around that time, but calling up friends and family, getting together, super important. And of course, therapy, counseling, CBT, and medication if indicated. And we all know this, getting out into the outdoors can really help stress levels. And you see it in the research. Like we've all seen this in the research. You go outdoors and it's amazing, but people's blood pressure drops, their salivary cortisol measurements, salivary cortisol goes down, and it's not really a surprise to us, but I'm happy there's research out there showing this. I think even looking at photos of the great outdoors can be helpful. So sometimes just encouraging people to have a book of photos and look through them when they're feeling stressed can be helpful. And y'all, some of you know this is Bryce National Park. Can anyone guess this one? This is Zion National Park. And here's Yosemite. There's Half Dome in the background. I climbed that when I was 11 years old. My parents used to take us backpacking here every year when we were little. And I just, kind of geek out these days and think, gosh, that must have been so good for my adrenals. But yeah, Yosemite has a special place in my heart. Anyone from Virginia? Here's Shenandoah National Park. And of course, just your local park can be helpful, just getting out into green space. And a side note, they have found that green space reflects infrared radiation. And what does infrared radiation do? It penetrates the skin. It actually goes pretty deep in the body, and it causes your mitochondria to increase production of melatonin, like internally in the mitochondria. And so being out in the green space, getting that infrared radiation can really improve your overall mitochondrial health. And we know mitochondria play a huge role in energy production, sex hormone production, cortisol production. So get out in the green space, lower your cortisol, improve PCOS, improve mitochondria. There's some calming herbs and adaptogens. Here's a list here. Some of my favorites are passion flower and chamomile. Valerian, just know it can be stimulating in 10% of the population. So if you use a valerian capsule or a tea, maybe try it away from other supplements to see if it's stimulating. Holy basil is a great adaptogen. It also helps regulate blood pressures, which is like a plus if someone has blood sugar dysregulation. I love ashwagandha, but it is a nightshade. So I do think if people have issues with nightshades, we should maybe reconsider, maybe not use ashwagandha. And L-theanine, GABA is great. Phosphatidylserine helps lower cortisol. This is not phosphatidylcholine. These are different. It's phosphatidylserine. Avoid intense exercise. So we don't want our PCOS patients flipping tires over every day, right? Intense exercise is going to increase cortisol, could elevate their androgens, it could lead to dysglycemia, can negatively affect our cardiovascular system, our immune system. It can shut down sex hormone production, affect fertility, lead to injuries and nutrient deficiencies. But we also don't want to underdo it. We don't want sedentary lifestyle because we know exercise improves insulin sensitivity. It reduces stress and anxiety. If we don't overdo it, it could lower our cortisol. It improves our sleep. It helps our mood. So all the things that we want for our PCOS patients. And I use the iFit app right now for exercise. The Down Dog is pretty good. I mean, these are kind of low cost apps, relatively low cost, where you can get high intensity interval training, you can get weightlifting, yoga, and much more. So of course, especially for our patients that have ovarian involvement, regulating the blood sugars is going to be important. And inositol and D-phenetol, a lot of times people these days are using myo-inositol or a combination of myo and D-chiroinositol in a 40-to-1 ratio. So more myo-inositol compared to D-chiroinositol, or just pure myo-inositol. That really helps regulate the blood sugars, lower the androgens. But you can have this in your back pocket. It's a great resource to look back on. There's some dosing ranges here too. And we've got our herbal anti-androgens. Here's a picture of cordyceps. It's cordyceps mushroom, isn't it beautiful? But these are all the herbal anti-androgens. And a lot of times I'm seeing people use spearmint tea. chamomile, which could also have that calming effect, right? Licorice and white peony, these lower androgens by increasing aromatase activity. And aromatase takes the androgens and converts them to estrogen. But use caution with licorice. It can be stimulating to the adrenals. It can increase blood pressure, so we don't want to give it to people with high blood pressure. We just want to use caution. And of course, our natural 5-alpha reductase blockers. So remember how testosterone gets converted to 5-alpha DHT by 5-alpha reductase? Well, these are natural things that we can use to block 5-alpha reductase activity. The pharmaceuticals are more finasteride, dutasteride, but those are pretty intense. Some people like to go with the more natural route. And I'm sure a lot of you know about saw palmetto and reishi mushroom. With the stinging nettle, just know it's not the leaf, it's the root. A lot of times we're using the leaf for allergies, but for 5-alpha reductase blocking effects, we want the root. And then lastly, we're going to support the circadian rhythm. So I think I listed way too many things here. All the things you can do to support your circadian rhythm, but I'm kind of passionate about it. I really like this topic. So I'm not going to go over all of them, just going to tell you my favorite ones. So it's great if people can get at least 30 minutes outdoors in the morning. I should take my own advice. But if they go out in the morning, no sunglasses. It doesn't count if they're in their car with all the windows rolled up. It doesn't count if they're in the office with the glass. But the good news is glasses and contacts don't interfere with the light therapy that's coming from the sun. And of course, you can get a happy light. Just want to make sure it's 10,000 lux. Use it before 9 a.m., 20 to 30 minutes. Usually people put it about 11 to 15 inches from their head. During the day, we can practice time-restricted eating. So that, if you do a gentle time-restricted eating, it means eating during daylight hours only and stopping by 7 p.m. at the latest. And trying to keep to a 12-hour window. It's funny, but a lot of times I look at what I'm eating and I'm keeping my eating window to like a 14 or 16-hour window, and I don't even realize it. And I'm only going 8 hours without eating. But it is important for the body to go, 12 or more hours without eating, to go through the detox, to sleep well, to reset. And eat earlier in the day rather than later, because insulin sensitivity is best in the morning. In the evening, we want to start winding down 1 to 2 hours before bedtime. Avoiding alcohol and sugar is important. Like, even if you drink alcohol and you pass out and you feel like you slept all night, it probably wasn't good quality sleep. And dim the lights with the sunset. And our intrinsically photosensitive retinal ganglion cells in our eyes are more easily activated by blue light than red light. And they're more activated by lights up high than lights down low. So 1 to 2 hours before bed or with the sunset, try not to turn on those overhead lights. Try to maybe turn on a lamp. And they have smart bulbs out there that'll block the blue light. So it's more like a red hue. But yeah, low level light, dim it. You can wear the blue light blocking glasses, the blue blockers. But the blue blockers, they don't work well if you wear them, but you have all the lights on in the house. And at night, what's my favorite thing here? Nightlight in the bathroom, or just go to the bathroom in the dark if you can. But nightlight is nice so you don't trip. And keep your bedroom cool. That's really going to help us sleep better. And they have mattress pads that will cool down the bed for you, cool down your body. And we always joke, the adrenals are boring. They like to go to bed at the same time. They like to wake up at the same time. I know I really like to do that. It makes me feel my best. So if we can support that circadian rhythm, if we can allow the HPA axis to kind of know when, get keep it consistent. Go to bed at the same time, wake up at the same time. Then the HPA axis, the brain's going to know when it should start elevating cortisol for the morning, when you should wake up. And at night, we want to really see how pets and children, how noises, how your partner's snoring, street lights could be affecting your sleep. And if you do think you have blood sugar dysregulation, really work on that. Think about a few grams of protein before bed might help regulate blood sugars as you're sleeping and improve sleep at night. So that's about it. Here are my references. And I think the big takeaway picture is the etiology of adrenal PCOS is not very clear, but we do have some things in our toolbox that we can do for our patients to improve our outcomes and to improve their signs and symptoms, right? And so I think it is important to really assess if there could be adrenal involvement and really look at a Dutch test and see, especially, do they have high cortisol? Because it could be really impacting their PCOS symptoms. And you'll have access to these slides. Hopefully you can have it in your back pocket. It'll be a great reference for you, and hopefully it will really help your patients. So thank you very much. Here's this last slide. Just want to, Alan already talked about this, but we have a lot of education on our provider portal for our Dutch providers. So check it out.
That's great. Thank you so much, Dr. Ruef. We appreciate the presentation. And if you have just a couple more minutes, we do have just a couple questions. I wanted to get a few of them out because there were a lot that came in. So one of the questions is, if you see some of the patterns that you showed on the case studies on the Dutch tests, and you suspect PCOS, would you see similar patterns through blood testing, or would you even need to do serum testing afterwards?
That's a really good question. So usually I like to do serum testing and the urine testing together. And that's mostly because one caveat to urine testing is sometimes testosterone comes back falsely low. And that's due to something called a UGT deletion. So basically, some people have a genetic variant. It doesn't affect their testosterone production, but it does affect how they metabolize their testosterone. And they tend to metabolize their testosterone into forms that we're not measuring in the urine, that no urine test measures. So their testosterone might actually come back falsely low. And I've seen this on adrenal reports before, but it doesn't affect the 5-alpha androstenediol marker. And so a lot of times I'll see, like, if someone has a UGT deletion, I'll see low testosterone, but their 5-alpha androstenediol is really high and their adrenal metabolites are really high. And so I still suspect, PCO, or not PCOS, but high androgens. So I do like to put them together, especially if testosterone comes back lower than I expected. Then I definitely do follow-up testing with testosterone or in the serum. But the Dutch test, we're looking at a lot of androgen metabolites that are not measured in the serum. So I really do think it can give us more, added insight into the androgen picture. And it can really tell us if they're pushing a lot of their androgens down that more potent pathway. If they are, they might have more symptoms of acne, more symptoms of hair loss, and we know people tend to push down the alpha pathway when they're inflamed, when they've got blood sugar dysregulation, and when they're overweight. So I do like to look at the Dutch test because I feel like it gives me a little added information. It might help me understand when to use the 5-alpha blockers, those the herbs that I mentioned. But it's another way to kind of track progress too.
That's great. Yeah, and you covered answers to a few other questions there too. You mentioned the 5-alpha blockers, and you showed the supplements and treatment considerations. Could you reiterate maybe some of your favorite 5-alpha inhibitors?
Oh, these 5-alpha inhibitors?
Yeah, show them up again.
Here they are.
There you go. Okay.
Well, I think Pygeum is endangered, so sometimes we stay away from that. But like saw palmetto, pretty famous one that people like to use. And stinging nettle root is also, I think, pretty effective. So I would say, I mean, I can't talk about specific products, but the product I like has these first three in it.
That's great. All right. Well, thanks very much. And that's all we have time for questions. There is a lot of other information on DutchTest.com about PCOS. We have past webinars, podcast episodes, and blogs. Dr. Ruef, you just posted a blog this month about PCOS and adrenal androgens. So check that out on DutchTest.com. So thanks everybody for joining us today. Check your inboxes tomorrow for a link to the webinar recording and to download the slides. Also, please visit DutchTest.com/providers and complete the steps to become a registered Dutch provider so you can gain access to all the educational resources we have available. So thanks again for everybody for joining us. Thank you, Dr. Ruef, and hope everybody enjoys the rest of your day.
Thank you.